This recording is the intellectual property of Anesthesia Compendium. Its contents are offered for education and remain, with our compliments, ours to safeguard.
Good morning. We are going to discuss the anesthetic management of the patient with cardiac disease presenting for non-cardiac surgery. To begin, why is this such an important topic?
Good morning. It is important because cardiac complications are among the leading causes of perioperative morbidity and mortality in non-cardiac surgery. Worldwide, several 100 million adults undergo major non-cardiac surgery each year, and a substantial proportion have established or undiagnosed cardiovascular disease, perioperative myocardial injury and infarction, heart failure, arrhythmia, and cardiac death account for a significant share of postoperative deaths. The anesthetist's task is to identify the patient at risk, optimize modifiable factors, choose a technique that protects the myocardium, and plan the postoperative environment to detect and treat complications early.
How do you stratify perioperative cardiac risk?
Risk is a function of three interacting domains: patient factors, surgical factors, and functional capacity. Both the American College of Cardiology and American Heart Association Guideline and the European Society of Cardiology Guideline, in their most recent iterations, structure the assessment around these domains, combined with validated risk indices. Patient factors are captured by indices such as the Revised Cardiac Risk Index. Surgical factors are stratified as low, intermediate, or high risk. Functional capacity is expressed in metabolic equivalents.
Tell me about the Revised Cardiac Risk Index.
The Revised Cardiac Risk Index, the LI Index published in 1999, is the most widely used bedside risk tool. It comprises 6 independent predictors, each scoring 1 point. High-risk surgery, intraperitoneal, intrathoracic or superinguinal vascular. Ischemic heart disease. History of congestive heart failure. History of cerebrovascular disease, insulin-treated diabetes mellitus, and preoperative creatinine above 177 micromoles per litre or 2 milligrams per deciliter. The risk of major cardiac complications rises with the score. Approximately 0.4% for 0 predictors, 0.9% for 1, 6.6% for 2, and over 11% for 3 or more. Its limitations are that it underestimates risk in vascular surgery and does not capture the severity of individual conditions.
Are there other risk tools you would use?
Yes. The American College of Surgeons NSQIP Surgical Risk Calculator is a procedure-specific online tool that estimates the risk of myocardial infarction or cardiac arrest from a wide range of variables, and is endorsed by the ACC/AHA guideline. The related Gupta-MICA model, myocardial infarction or cardiac arrest, is another regression-based calculator. The ESC guideline additionally incorporates age and a wider set of comorbidities, and places greater emphasis on biomarkers, natriuretic peptides, than the American guideline historically did. No single tool is perfect. I would use a validated index as a starting point and refine it with functional capacity and biomarkers.
This recording is the intellectual property of Anesthesia Compendium. Its contents are offered for education and remain, with our compliments, ours to safeguard.
You mentioned functional capacity. How is it assessed?
Functional capacity is the single most useful clinical discriminator of perioperative cardiac risk, and it is expressed in metabolic equivalents, or METs. 1 MET is the resting oxygen consumption of approximately 3.5 milliliters per kilogram per minute. The clinically important threshold is 4 METs, the ability to climb 2 flights of stairs, walk up a hill, or undertake moderate household work. A patient who can achieve 4 METs or more without cardiac symptoms generally tolerates major surgery well, and extensive cardiac investigation is usually unnecessary. A patient who cannot achieve 4 METs, or whose capacity is unknown because of immobility, warrants closer evaluation if the surgery is intermediate or high risk.
Is subjective assessment of METs reliable?
This is an important caveat. The MET study, published in 2018, showed that subjective clinical assessment of functional capacity correlates poorly with objectively measured fitness and does not reliably predict complications. This has shifted practice towards structured questionnaires, such as the Duke Activity Status Index, towards biomarkers, and, where available, towards cardiopulmonary exercise testing for objective measurement. So while 4 METs remains a useful conceptual threshold, I would not rely on an offhand subjective estimate alone for a high-risk case.
Tell me about cardiopulmonary exercise testing.
Cardiopulmonary exercise testing, CPET, provides an objective, integrated measurement of cardiorespiratory reserve under controlled, incremental exercise. The key variables are the anaerobic threshold, the peak oxygen uptake, and the ventilatory equivalence for carbon dioxide, which reflects ventilatory efficiency. An anaerobic threshold below approximately 11 milliliters per kilogram per minute, and a peak oxygen uptake below a procedure-dependent threshold. Identify patients at elevated risk of perioperative complications and prolonged recovery. It is increasingly used in major elective surgery, particularly major abdominal, vascular, and thoracic, both to stratify risk and to inform shared decision-making and the planning of critical care.
How is surgical risk categorized?
Both major guidelines stratify procedures by their 30-day risk of cardiac death or myocardial infarction. Low risk under 1%, superficial, breast, dental, endocrine, ophthalmic, and minor gynecological or orthopedic procedures. Intermediate risk 1 to 5%, intraperitoneal, carotid, head and neck, major orthopedic and urological surgery. High risk over 5%, aortic and major vascular surgery, and major prolonged procedures with large fluid shifts. The ESC guideline uses a similar 3-tier system. Surgical risk and patient risk are considered together. A high-risk patient for low-risk surgery may need little workup, whereas a moderate-risk patient for high-risk surgery may need extensive evaluation.
This recording is the intellectual property of Anesthesia Compendium. Its contents are offered for education and remain, with our compliments, ours to safeguard.
When do you order a resting ECG?
Guideline recommendations have become more conservative over time, reflecting evidence that routine testing rarely changes management. The ACC/AH guideline suggests a resting 12-lead ECG is reasonable for patients with known coronary artery disease, significant arrhythmia, peripheral arterial disease, cerebrovascular disease, or other significant structural heart disease, except for low-risk surgery. It is not recommended routinely for asymptomatic patients undergoing low-risk surgery. The ECG provides a baseline, may reveal prior silent infarction, left ventricular hypertrophy, or arrhythmia, but a normal ECG does not exclude significant coronary disease.
Echocardiography.
Resting transthoracic echocardiography is not a routine screening test. It is indicated for dyspnea of unknown origin, for clinical deterioration or change in a patient with known heart failure, and for the evaluation of a previously undocumented murmur suggestive of significant valvular disease before high-risk surgery. It provides ventricular function, valve assessment, and an estimate of pulmonary pressures, all of which inform the anesthetic plan. The decision to obtain it should be based on whether the result will change management, not on the surgery alone.
What about biomarkers? Where do they fit?
Biomarkers have become central to the European approach and increasingly important elsewhere. The ESC guideline recommends measuring natriuretic peptides, BNP or NT-proBNP, before intermediate and high-risk surgery in patients over a certain age or with cardiovascular risk factors, because an elevated preoperative concentration strongly predicts perioperative cardiac events and death. The Canadian Cardiovascular Society guideline goes further, recommending routine preoperative natriuretic peptide measurement in defined groups, followed by postoperative high-sensitivity troponin surveillance. The rationale is the recognition of myocardial injury after non-cardiac surgery, MINS, much of which is silent and would be missed without systematic troponin measurement.
Expand on myocardial injury after non-cardiac surgery.
Myocardial injury after non-cardiac surgery, MINS, is defined as myocardial injury, evidenced by a raised troponin, caused by ischemia, occurring within 30 days of surgery, whether or not it meets the universal definition of myocardial infarction. It is common, affecting up to 1 in 5 high-risk patients, and is frequently silent, without chest pain or ECG changes, because of residual analgesia, sedation, and the postoperative state. It is strongly associated with 30-day mortality. The clinical implications are, first, that systematic troponin surveillance in high-risk patients detects events that would otherwise be missed. And second, that detection should trigger cardiology review, intensification of secondary prevention, statin, antiplatelet and risk factor management, and investigation for a treatable cause.
This recording is the intellectual property of Anesthesia Compendium. Its contents are offered for education and remain, with our compliments, ours to safeguard.
A patient with stable ischemic heart disease needs an elective hip replacement. Would you refer for coronary revascularization before surgery?
Generally no, and this is an important and well-evidenced point. The landmark CARP trial, coronary artery revascularization prophylaxis, demonstrated that prophylactic coronary revascularization before major vascular surgery does not improve outcomes in patients with stable coronary disease, compared with optimal medical therapy. Revascularization should therefore be undertaken only for the same indications as in the non-operative setting. For example, an acute coronary syndrome, left main disease or refractory symptoms, not as a prophylactic measure to get the patient through surgery. For this patient, I would optimize medical therapy, ensure good functional capacity and proceed.
What if the patient had a recent coronary stent?
This changes everything because of dual antiplatelet therapy and the risk of stent thrombosis. Stopping antiplatelet therapy prematurely after stenting is associated with catastrophic stent thrombosis, which carries a high mortality. The guidance, common to a CC/AHR and ESC, is to defer elective non-cardiac surgery until a minimum interval has elapsed. For a bare metal stent, historically a minimum of 1 month. For a drug-eluting stent, the current recommendation is to wait at least 6 months for elective surgery, and a reasonable minimum of 3 months if the surgery cannot safely be delayed, and the risk of further delay outweighs the risk of stent thrombosis. Throughout, I would manage the patient in conjunction with a cardiologist, ideally continuing aspirin through the perioperative period, wherever the bleeding risk allows, and bridging or timing the second agent, clopidogrel, ticagrelor or prasugrel, according to a multidisciplinary plan.
How do you manage dual antiplatelet therapy in the perioperative period?
Through a multidisciplinary, individualized plan balancing thrombotic and bleeding risk. The principles: continue aspirin unless the bleeding risk is prohibitive, intracranial, intraocular posterior chamber, or some prostate surgery. Stop the P2Y12 inhibitor for a drug-specific interval before surgery where bleeding risk demands. 5 days for clopidogrel, 5 to 7 days for ticagrelor, 7 days for prasugrel. Time the surgery to fall outside the mandatory dual therapy window, after stenting wherever possible. Restart antiplatelet therapy as soon as hemostasis allows postoperatively. For high thrombotic risk requiring P2Y12 cessation, bridging with a short-acting agent, a glycoprotein inhibitor or cangrelor, may be considered in specialist centers, though the evidence base is limited.
This recording is the intellectual property of Anesthesia Compendium. Its contents are offered for education and remain, with our compliments, ours to safeguard.
Let's talk about cardiovascular medications. Beta blockers, continue or stop.
Continue chronic beta blockade through the perioperative period. Abrupt withdrawal causes rebound tachycardia, hypertension and ischemia. The more contentious question is the initiation of beta blockade de novo before surgery. The POISE trial in 2008 showed that starting high-dose metoprolol shortly before surgery reduced myocardial infarction, but increased total mortality and stroke, driven by hypotension and bradycardia. Consequently, the guidelines advise that beta blockers should not be started routinely on the day of surgery. If de novo beta blockade is indicated, for example, in a patient with multiple risk factors or known ischemia, it should be started well in advance, days to weeks, and titrated carefully to heart rate and blood pressure.
Statins.
Continue statins, and indeed they are one of the few drugs the guidelines actively recommend starting before high-risk surgery, particularly vascular surgery. Statins have pleiotropic plaque-stabilizing and anti-inflammatory effects beyond lipid lowering, and continuation through surgery is associated with reduced cardiac events. Abrupt withdrawal may be harmful. I would ensure the patient takes their statin on the morning of surgery and resumes it promptly afterwards.
ACE inhibitors and angiotensin receptor blockers.
This is nuanced and the guidelines differ slightly. These drugs blunt the compensatory response to the hypovolemia and vasodilation of anesthesia, and continuing them is associated with intraoperative hypotension. The pragmatic, widely adopted approach is to withhold the morning dose on the day of surgery when the drug is taken for hypertension, and to continue it when it is taken for heart failure with reduced ejection fraction, where the benefit is greater, restarting once the patient is euvolemic postoperatively. The ESC guideline supports considering withholding before major surgery. The decision should weigh the indication against the hypotension risk.
Other agents, diuretics, calcium channel blockers, anticoagulants.
Briefly, diuretics, usually withheld on the morning of surgery to avoid hypovolemia and electrolyte disturbance, then resumed. Calcium channel blockers continued. Oral anticoagulants, warfarin stopped 5 days before surgery with INR checked and bridging, considered for high thrombotic risk such as mechanical valves. Direct oral anticoagulants stopped for a drug and renal function specific interval, typically 2 to 3 days, longer for high bleeding risk surgery. Newer agents, SGLT2 inhibitors should be withheld 3 to 4 days preoperatively because of the risk of euglycemic ketoacidosis.
This recording is the intellectual property of Anesthesia Compendium. Its contents are offered for education and remain, with our compliments, ours to safeguard.
Let's consider valvular disease. Which lesion concerns you most and why?
Severe aortic stenosis is the lesion that concerns me most. The fixed obstruction to left ventricular outflow means the heart cannot increase cardiac output in response to vasodilation or hypovolemia, and the hypertrophied ventricle is critically dependent on coronary perfusion pressure and on preload. Severe aortic stenosis is defined by a valve area below 1 square centimeter, a mean gradient above 40 millimeters of mercury, or a peak velocity above 4 meters per second. Symptomatic severe aortic stenosis, angina, syncope, or heart failure carries a markedly elevated perioperative risk, and where the surgery is elective, valve intervention should be considered first.
What are your hemodynamic goals for severe aortic stenosis?
I summarize them as full, slow, tight, and in sinus rhythm. Full, maintain preload. The stiff ventricle needs adequate filling. Slow, avoid tachycardia, which reduces diastolic coronary filling time and ventricular filling. Aim for a controlled normal heart rate. Tight, maintain systemic vascular resistance and coronary perfusion pressure. Treat hypotension promptly and aggressively with an alpha agonist, such as phenylephrine or metaraminol. Sinus rhythm. The atrial contribution to filling of the non-compliant ventricle is substantial. New atrial fibrillation is poorly tolerated and may require prompt cardioversion. Practically, this means invasive arterial monitoring, careful titrated induction, avoidance of abrupt vasodilation, and consideration of the limitations of neuraxial techniques, where sympathectomy can be catastrophic.
Contrast that with the regurgitant lesions.
The regurgitant lesions have opposite goals. Aortic regurgitation and mitral regurgitation both benefit from a slightly faster heart rate, to reduce regurgitant time, afterload reduction to favor forward flow, and maintained preload. So for the regurgitant lesions, the maxim is fast, full, and forward. Avoid bradycardia, avoid increases in afterload, and maintain filling. Mitral stenosis, by contrast, behaves more like aortic stenosis in its preference for a controlled heart rate and maintained preload, with the additional concern of pulmonary hypertension and the avoidance of factors that raise pulmonary vascular resistance. In every case, I would seek a recent echocardiogram and, for severe lesions, discuss the patient with a cardiologist before elective surgery.
This recording is the intellectual property of Anesthesia Compendium. Its contents are offered for education and remain, with our compliments, ours to safeguard.
How does heart failure influence your assessment?
Heart failure is one of the strongest predictors of adverse perioperative outcome, more so than coronary disease in many series. I would characterize it: reduced or preserved ejection fraction, current symptoms and New York Heart Association class, recent decompensation and current therapy. A patient with decompensated or newly diagnosed heart failure should have elective surgery deferred for optimization, with echocardiography and natriuretic peptide measurement. A patient with stable, well-managed heart failure can proceed with attention to fluid balance, continuation of guideline-directed medical therapy, where appropriate, invasive monitoring for major surgery, and a planned higher level of postoperative care. Both a CC/AH and ESC identify active heart failure as a condition warranting evaluation and optimization before elective surgery.
A patient has an implantable cardioverter defibrillator. What are your considerations?
A cardiac implantable electronic device, pacemaker, ICD, or cardiac resynchronization device requires specific perioperative management set out in dedicated Heart Rhythm Society and British Heart Rhythm Society guidance. Preoperatively, identify the device type, manufacturer, indication, last check, ideally within the recommended interval, battery status, and the patient's underlying rhythm and pacing dependence. The principal interoperative hazard is electromagnetic interference from monopolar diathermy, which a pacemaker may misinterpret, or which an ICD may interpret as a tachyarrhythmia and deliver an inappropriate shock. Mitigation: use bipolar diathermy where possible. If monopolar is used, position the return plate so the current path avoids the device. Use short bursts. For an ICD, the tachyarrhythmia therapy should be suspended, either by reprogramming or by a correctly positioned magnet, with external defibrillation immediately available and reactivated postoperatively. A pacing-dependent patient may need the pacemaker set to an asynchronous mode to prevent inappropriate inhibition. Device interrogation before and after surgery, with cardiac physiology support, is the standard of care.
Atrial fibrillation discovered at the preoperative visit. What do you do?
Assess rate, stability, and anticoagulation. New or uncontrolled atrial fibrillation warrants investigation for a precipitant, ischemia, sepsis, electrolyte disturbance, thyroid dysfunction, pulmonary embolism. For elective surgery, I would optimize rate control and address anticoagulation according to the CH, a 2DS2 VASC stroke risk. For urgent surgery with a fast ventricular rate, I would control the rate intraoperatively, beta blocker, or amiodarone in the hemodynamically compromised, and be prepared for synchronized cardioversion if there is hemodynamic instability attributable to the arrhythmia.
This recording is the intellectual property of Anesthesia Compendium. Its contents are offered for education and remain, with our compliments, ours to safeguard.
What are your intraoperative monitoring choices for a high-risk cardiac patient undergoing major surgery?
Monitoring proportionate to the patient and the procedure. Standard monitoring as a minimum, with 5-lead ECG and ST segment analysis. Leads Roman 2 and V5 together detect the majority of ischemic events. Invasive arterial blood pressure, cited before induction for the highest risk patients, for beat-to-beat pressure and blood sampling. Central venous access for vasoactive infusions, with central venous pressure as a trend rather than an absolute. Cardiac output monitoring, esophageal Doppler arterial waveform analysis, or similar, to guide fluid and vasoactive therapy in major surgery. Transesophageal echocardiography for the highest risk patients, or where acute hemodynamic instability requires diagnosis. It directly visualizes ventricular filling, regional wall motion, and valve function. Depth of anesthesia, temperature, neuromuscular and urine output monitoring as indicated.
What are your hemodynamic goals in general terms?
The overarching aim is to maintain the balance between myocardial oxygen supply and demand. Supply is favored by adequate coronary perfusion pressure, diastolic blood pressure, adequate oxygen content, and avoidance of tachycardia, which shortens diastole. Demand is reduced by controlling heart rate, avoiding hypertension and excessive contractility, and maintaining normothermia to prevent shivering. Practically, keep the heart rate controlled and the blood pressure within 20% of baseline, avoid both hypotension and hypertensive surges, maintain normovolemia, normothermia and a normal hematocrit, and treat anemia, pain and light anesthesia, all of which drive myocardial oxygen demand.
Is regional anesthesia protective?
The evidence is nuanced. Neuraxial and regional techniques offer excellent analgesia, reduced opioid requirement, attenuation of the surgical stress response, and a lower incidence of respiratory complications. and there is observational evidence of benefit in some populations. However, large randomized trials have not consistently shown a mortality benefit over a well-conducted general anesthetic with multimodal analgesia. The hemodynamic effects of neuraxial block, sympathectomy, hypotension, can be hazardous in fixed-output states such as severe aortic stenosis. My approach is to use regional techniques for their analgesic and stress-reducing benefits, where the hemodynamic profile suits the patient, rather than regarding them as universally cardioprotective.
This recording is the intellectual property of Anesthesia Compendium. Its contents are offered for education and remain, with our compliments, ours to safeguard.
Where does the high-risk cardiac patient go after surgery, and what do you watch for?
The decision is made before induction. The high-risk cardiac patient undergoing major surgery should recover in an environment with continuous ECG and hemodynamic monitoring, a high-dependency or intensive care bed, for at least the first 24 to 72 hours, the period of highest risk. I would institute systematic troponin surveillance to detect myocardial injury after non-cardiac surgery, effective multimodal analgesia to control the sympathetic stress response, careful fluid balance, resumption of cardiovascular medications as soon as appropriate, and vigilance for arrhythmia, heart failure, and ischemia. Early detection and a clear escalation plan, with cardiology input, are what convert a detected complication into a survivable one.
Final question, 5 take-home messages.
1. Stratify risk using a validated index, surgical risk, and functional capacity together. Remember that subjective met-estimation is unreliable, and consider biomarkers and CPET for objective assessment. 2. Investigate only when the result will change management. Routine ECG and echocardiography in asymptomatic patients are discouraged by both the American and European guidelines. 3. Do not revascularize prophylactically. The CARP trial settled this. Respect the mandatory antiplatelet window after coronary stenting. 4. Continue beta blockers and statins, but do not start beta blockers on the day of surgery. POISE showed the harm. Manage ACE inhibitors, anticoagulants, and SGLT2 inhibitors with a clear plan. 5. Match the hemodynamic plan to the lesion. Full, slow, tight, and in sinus rhythm for aortic stenosis. Fast, full, and forward for the regurgitant lesions, and plan the postoperative environment, including troponin surveillance before induction.
Thank you. That concludes this station.
This recording is the intellectual property of Anesthesia Compendium. Its contents are offered for education and remain, with our compliments, ours to safeguard.